Yesterday's fantastic session, scientific session, and today morning's scrumptious breakfast and the paper presentations. I'm sure all of you are really looking forward for the scientific treat today. So Dr. Vinay, can you tell us what is in store for our grey cells today?
So, hello, yeah, am I audible?
Yes.
Yeah. So आगाज ऐसा था तो अंजाम क्या होगा सोचो. So those who were there yesterday enjoyed all the food for thought and gastronomical delights, won't be disappointed. So today we have topics ranging from ICU to nervous system to gastro. We had a session in the morning that we concluded just now to a mega event of the oration today.
So that's just great, Vinay. So we're really looking forward to today's session too. But before we start with that, after the photo session, I would like to call upon the President of Navi Mumbai IAP. I would like to call upon Dr. Satish Shahane, President of Navi Mumbai IAP, to welcome the audience.
So thank you, and good morning all. Good morning, everybody awake with a great tea and hospitality. So friends, yesterday was a superb session with all three kinds: science, food and cultural. It was a fantastic event and we are still having the hangover of that cultural event yesterday night. It was very well organized. And today also we'll have the fantastic session ahead, and I congratulate all IAP Navi Mumbai and Mumbai team and organizing team and our mentors for this wonderful alliance. So it was the brainchild of Dr. Nitin Shah and Dr. Vijay Ule, and it was indeed a, I would say, feast for all, both science and as well as cultural. So I'll just for both of them I'll just mention one share for them. So good morning friends. ढल जाती है हर चीज़, ढल जाती है हर चीज़ अपने वक्त पर, ढल जाती है हर चीज़ अपने वक्त पर, सिर्फ प्यार और लगाव कभी बुरा नहीं होता. Okay. So this we have to continue and this legacy will continue. Thank you very much and enjoy the science.
Thank you, Dr. Satish. We now kickstart our scientific session for today. I would request all the audience to please come ahead. It'll be very nice to have an interactive session here with our speakers. So we're going to start with an intensive care in a nutshell with quick bites and big impacts. The first speaker for it will be Dr. Minaj Sheikh, who is a pediatric intensivist at Lilavati Hospital, for his talk on maintenance fluids. We welcome you, sir.
Respected senior, dear friends, good morning. It's been absolute pleasure to be here on the prime time, starting with the flutes. And we know the flutes. The flute is required right from cradle to the end, though the format, the combination and the need is variable. And why we need flute, we need to understand. Primarily, it's to stabilize the hemodynamics, to return ICF to normal, replace ongoing losses if any, provide glucose which is required for the brain, and of course the maintenance fluids. And what are the phases that we need the fluid? We need the fluid on resuscitation phase, replacement, and the maintenance. Today I'll be dealing with the maintenance fluid. And why we need the fluid? There have been the case reports way back in 2000, 2010 in UK, Manchester, wherein 13-month-old child brought with diarrhea, vomiting, moderate dehydration, serum sodium 137, received IV fluid 4% dextrose with 0.18% saline, and within 12 hours developed seizures, cerebral edema, and fixed pupil and died. And what was found over there was there is consistent hyponatremia, and it is known. Can I have the pointer, please? And it's known, that low sodium is associated with brain swelling, And this has been way back in 1976. The IAP, which has an experimental model, animal experimental model, has demonstrated significant drop of sodium from 139 to 119 has high mortality. So sodium is hyponatremia, acute hyponatremia is known to have cerebral edema and consequences thereupon. So, coming to basics, some basics about the fluid electrolytes. We know as the younger the child, the total body water is on the higher side. As the age advances, total body water decreases. The ECF, the extracellular compartment, is higher on the younger side. The ICF is higher as the age advances. So this is the basics with regard to percentage. And then some body compartment and its distribution. We know the 2/3 of the total body water, which is 60% of the body weight, is intracellular and 1/3 is extracellular. Of the extracellular, 3/4 is interstitial fluid and 1/4 is intravascular fluid. Mind, what we modify is to begin with intravascular compartment, and then there is a change in the fluid that we'll talk about, and how it changes is important to understand. So simple to remember, 2/3, 1/3, total body water 60%, 2/3 is intracellular, 1/3 is extracellular. Of the 1/3, 3/4 is interstitial and 1/4 is intravascular compartment. So by and large, 6 to 8% is the actual intravascular compartment that we actually modify, and then thereupon the shifting of fluid here and there from intracellular to extracellular compartment. Well, having known about the fluid, we should know about the cations. And the important cations of the extracellular compartment is sodium. So sodium is 140. Actual sodium is 155. So where this 140 is come, this 140 is because of the dilution by the albumin. So albumin is the correction factor for the sodium. Actual sodium is 155. So 140 is your sodium. Potassium is 4 in the extracellular compartment, and the osmolality is 280. Whereby we have to understand the main cation of the intracellular compartment is potassium. That's 150. And another important thing is osmolality. If you see the osmolality, on either side, it is equal. So this equilibrium osmolality is essential for the cell size, the cell integrity that we'll come to understand. So beware, sodium is extracellular electrolytes and potassium is intracellular electrolyte. Well, some back to basics again. This is important slides. Kidneys sense water, but not sodium. 1% change in the body weight is sensed by the brain, and accordingly this change in the water composition of the body. 1% change, that's important. And it is the water, not the sodium, which is sensed by the brain. However, this is important. Salt sucks the water. What is this? Is fluid shift. So what is this? This is lady with the lamb. Wherever the lady will go, the lamb will go. The lady is sodium, lamb is water. So remember this thing, wherever the sodium will be there, water will be there. This is important concept to understand. Okay, coming back to again basics, we often talk about osmolality, tonicity. What all about is this? So osmolality is always compared with plasma. Mind, osmolality is always compared with plasma, and tonicity is always compared with the cell. So osmolality is number of osmoles, solute or particle dissolved in plasma. Again, we talk about osmolality and osmolarity. So what is osmolality? The osmolality is the number of solutes or particles per kg of plasma. So when we have L, it is kg. So osmolality is with the kg, and osmolarity is the liter. So this is all about the osmolality, and the plasma osmolality we calculate by 2 sodium into glucose by 18 and burn by 2.8. Coming to tonicity. So what is tonicity? Tonicity is effective osmolality. You may have osmolality, but it may not be effective. To be effective, you have to have the sodium, and the sodium is an important component for tonicity. And what is the importance of tonicity is that it is compared with the cell membrane. So tonicity is the effective osmoles which actually create the osmotic gradients across the cell membrane. So tonicity is important, and for that tonicity, the formula is 2 into sodium. Well, the plasma osmolality or osmolarity is 275 to 295. Anything below 275 is hypoosmolar. Anything above 295 is hyperosmolar. So physiologically, essential for isoosmolar plasma, urine is either concentrated or diluted. So if you have a hyperosmolar plasma, you have plasma osmolarity more than urine osmolarity, you have hyperosmolar urine. And the clinical status is your DI. Other way around, if you have hyperosmolar plasma, your plasma osmolarity is less, plasma osmolarity is less than urine osmolarity, and the condition is SIDH. So we need to understand the osmolarity and its physiological implications. What about tonicity? This is important. The tonicity is 2 by sodium, responsible for movement of water across the cell membrane. Whenever you have hypotonicity, so fluid will go from inside of the cell to outside. So there will be, the hypotonicity, the fluid will go from outside to inside, and the cell swelling will be there. Whenever you have hypertonicity, the fluid will go out. So this is an important concept. Wherever the sodium will go, the fluid will go. Now coming to the topic proper, that's what maintenance fluid we should have, which fluid, how much, and what route. So for that, we need to understand how we calculate the fluid. The first is body water versus body surface area. We used to have body water, the present body weight, the ideal body weight, or what is called as lean body weight. So younger the child, higher the surface area, we tend to have the more, if you calculate by the body surface area, more fluid. That is why up to 30 kg, we can calculate by the body weight. Beyond 30 kg, we should calculate by the body surface area. For the weight also, which weight? Present weight, adult body weight, or lean body weight? Ideally, lean body weight. What is lean body weight? Is 50th centile or ideal body weight. But we don't have the centile for lean body weight and all those things. That's why we go with the present body weight. This is important when the child becomes older and you have that obese child and all those things. So these things are important to understand. Next is note all losses. We often tend to forget the losses. So it's very important where the losses are there. Check electrolytes and sugar and know about your fluids. I also need some fluids, sorry. Well, the sources of fluid losses traditionally have been told urine 60%, insensible water loss 35%, stool 5%, making it insensible water loss approximately 400 ml per meter square per day. And these are the sources of your fluid losses. Know about your fluids. This is important. So you have 5% dextrose, 0.5% DNS, 0.51%, and so all of us are isoosmolar or hypoosmolar. But what is important is we need to understand the tonicity. We don't want hypotonic fluid. So all these fluids are out of box nowadays. What we need is isotonic fluid, which may be ringal lactate, plasmalite, and so. But important for ringal lactate and plasmalite, they don't have dextrose. So we need to add dextrose to plasmalite. We need to have ringal lactate when have the. We need to have dextrose when you are ringal lactate or plasmalite. So these things are important with regard to your fluids. Coming to maintenance fluid by Holiday-Segar formula, all of us we know, we are going to challenge this Holiday-Segar formula, how it is right or otherwise. How it is happen. So this is Boston Salt and Water Club. We have Boston Tea Party way back in 1774. This is the Boston Salt Club. What is Boston Salt Club? If you go and see in the literature, they talk about this is a club which has been there in the last 70 years, and they have a meeting every 2 years, offline, online, and they discuss about salt and water. And these are the important people who were there. This is 1943. The Holiday, the Cigar, the Gamble, and the Wallace. They were the dawn of the fluid electrolyte that time. Whatever they said was taken as a gospel truth, which may or may not be. So we'll talk about what is right or not. So the Holiday-Segar formula, what they did, this is based on the daily caloric requirement, first 10 kg, 10, 20 kg, and more than 20 kg. Based on the caloric requirement, they calculated the maintenance fluid. We'll come to that, whether it is right or not. So what they did, very important. The entire concept of Holiday-Segar formula is on 53 patients. 25 infants, 25 children, 8 adults. And what they did, they coupled the fluid needs to energy expenditure, which need not be necessarily always right. We'll say why it is not. Then they use kg rather than body surface area. They thought it is very difficult to have the body surface area calculation for the normal population and all those things. So they straightway went for the kg. And they had a weight band, the wider weight band, 20 kg, 40 kg, 60 kg. And they talked about basal metabolic rate from Talbot. What is Talbot? It is important to understand. This scientist has talked about the the energy expenditure with regard to basal metabolic rate, BMR. And for that particular, he had only 7 infants. For that particular BMR, the entire holiday cigar formula based on the BMR is on 7 patients of 53 patients. This is important. If you dissect the holiday cigar formula, you understand it actually overestimates. So how it overestimates, we'll come to that. So this is the actual BMR, basal metabolic rate. So this is the actual calorie requirement for BMR. And this is estimated for the normal. And again important, the entire holiday cigar formula was for the healthy children, not for the sick children. So the entire BMR, the holiday cigar is now questioned. And what is the question is that going by this, we are actually giving overfluids. So we have to be less with regard to holiday cigar formula. This is all about holiday cigar. And then we often overestimate the fluid losses. Historically, as I said in the previous slides, that 25%, 15%, and all those losses, the sum is in the historically 100 ml per kg per day. However, in acute illness, the actual losses are only 30 to 44 ml per kg. So our losses are also goes down. Then we have overestimated the energy expenditure. That's what we talked about. Actually, we need only 70 to 60 calories per energy requirement. So major energy expenditure by your fancy calculations nowadays is in sick children is only 42 plus 9. So we actually have excessive energy which has been calculated during the critical illness also. So all this coupled together makes the fluid on the higher side by the traditional way of calculation. So what is the fluid changes? Acutely ill hospitalized children, excess ADH, we need to understand, we have to they produce hyponatremia. Reduced renal water loss, they have reduced renal water clearance and produce processed water retention. So, one size not fit for all, and there is no cookbook approach. So, what compartment we want to actually target? So basically, if you want to expand, you can give 0.9 saline. If you want to ICF, you want to expand D5 water. And this is the choice of fluid. If you have 5% dextrose, it is a free water. It goes in almost all compartments from ICF to ECF. If you want to target, you only can give the ringer-lactate normal saline, which is stayed in the ICF. And if you have albumin, it's stayed in the your intravascular compartment. So keeping in mind what kind of fluid you want, primarily you want to first optimize the hemodynamics, keep a proper preload, and then afterwards you have types of fluid that we talked about. So what about colloid and crystalloids? There have been a lot of debates. These are the various studies which has been there. And finally, what is the outcome is that there is no advantage of colloid over crystalloid. There is no advantage of balanced salt solution and oral saline in critically ill child. So what is so coming back to normal saline? What is normal about normal saline? So normal saline has 154 milliequivalent of sodium, however plasma is 145. Chlorides 155, it is not in the plasma, 96. So saline is neither normal nor physiological. This is important about normal saline. It's neither normal nor physiological. However, still we give normal saline because it does not affect the cell volume and cell function to large extent. So what's the important message is avoid hypertonic fluid, use only isotopic slide. So a word about use of isolate P. We should not use isolate P. Why? Because, I will take 2 more minutes extra. Because you have an osmolarity of 340, but see the sodium. Sodium is 23. Your tonicity is hardly, 23 into 2 is 46, which is grossly hypertonic. So one thing, if you want to have, remove isolate P from our hospitals and inventory. This is important. Do not use hypertonic slides, hypertonic fluids. This was a patient safety alert way back in 2007 in NHS, where they actually, this was the fluid which was proposed by Holiday Cigar from 1946 till 2007, and they used to have the case report that I said in the beginning. And then this was the formula which they were using, 0.1 sodium chloride, 4% glucose, and which was banned in 2007. Having said all these things, what are the key fluids for sick children? It should be isotonic, preferably crystalloid, and have some glucose. Even this 5% glucose is more. Actually, brain needs only 2 to 4 milligram per kg per minute glucose also. So you can have 2 to 4% glucose as well. So is the same fluid prescription to all disease condition? No. What we can have is that if we have renal failure, the classical formula is 400 ml per meter square plus urine output plus your insulin. So this is the way we can have 1/3 of the maintenance in renal failure, SIDH 0.7 into maintenance, congestive heart failure, you can come down to the 50% of the fluid requirement, and milliliter almost 1 cent. These are the type of fluids which we can recommend. I'll skip all those things and coming to the business, that's what type of fluid therapy that we want, either restrictive or liberal approach. No, if you have restricted fluid therapy, increase of hypovolemia, organ dysfunction, impaired oxygen delivery. Liberal approach, you can hypervolemia and consequence thereupon. So what actually we need the fluid which is moderate, rational, and less is more. So this is the art of fluid administration. Run them little sweet and little dry, low glucose, not too much of low glucose, maintaining sugar from 80 to 140 milligram per. It took them a while to get this away. It's okay if it takes them a while to get better. So the take to work message, no more take to home message. Home is different, work is different. Remain to work only, don't take to home, and preserve cell volume integrity. When we talk about fluid, it is not about the fluid, it is the preservation of the cell volume and integrity. And then keep ECF isotonic maintenance fluid, hypertonic fluid no longer recommended, restrict fluid in the IDH, and monitor electrolytes when you have IV fluids. Thank you for the patient sharing. Oh, thank you.
Thank you for that wonderful session, Dr. Sheikh. I would now like to request the organizing secretary of Mumbai IAP, Dr. Shikha Agrawal, to felicitate Dr. Sheikh. So after that fantastic talk on intensive care fluids, we now move on to the next session by Dr. Soumya Renji, a pediatric intensivist from PD Hinduja Hospital on NIV. We welcome you, ma'am.
वर टॉपला
Good morning, everyone. Okay. So today I'm going to talk about non-invasive ventilation. What is non-invasive ventilation? Non-invasive ventilation is delivery of mechanical ventilation without endotracheal intubation. What are indications for non-invasive ventilation? In acute hypoxic respiratory failure, you can use where there is asthma, pneumonia, atelectasis, in cardiogenic pulmonary edema, to facilitate early extubation and from the ventilators, for neuromuscular disorders where the airway reflexes and bulbar reflexes are preserved, and in immunocompromised patients to avoid infections. What are contraindications for NIV? You have to avoid NIV if you think there is imminent need for intubation, if there may be a possibility of CPR if you think. In a hemodynamically unstable child, please avoid NIV. If the GCS is less than 8 and rapidly declining, if there is a high risk of aspiration, inability to protect the airway, if there is copious secretions, recurrent vomiting, in these children we would not suggest the use of NIV. If there is upper GI bleed, bowel obstruction, fixed upper airway obstruction, facial injuries, burns, anomalies, because the interface would not be able to fit in such cases, and untreated pneumothorax. What are the modes of NIV that we have? So there is a CPAP and BiPAP mode. In CPAP, you give a continuous positive airway pressure. There is application of a constant pressure throughout the cycle. which is equivalent of a positive end expiratory pressure. The patient breathes spontaneously at baseline pressure and controls the rate and depth of respiration. The flow and pressure transducers respond to the patient's efforts and maintain pressure. It is used in hypoxemic child. What does CPAP do? It opens the alveoli and keeps it open, called as alveolar recruitment. Then there is BiPAP. In BiPAP, you deliver two sets of positive airway pressure, the IPAP and the EPAP. The IPAP is the inspiratory positive airway pressure or the pressure support, and the EPAP expiratory pressure, which keeps the airway open in the expiration. So the ventilator detects inspiratory flow. It delivers a high inspiratory pressure until it senses a reduction in the flow or when it reaches a set inspiratory time limit. So the inspiration terminates based on flow or time, and the device cycles to the lower expiratory pressure. This is how the breathing occurs on both the modes. In BiPAP, there is spontaneous breathing on both pressure levels, while in CPAP, there is spontaneous breathing on one pressure level. So these are the interfaces available for giving non-invasive ventilation. The first one is the full face mask. Then there are nasal mask. Now there are newer interfaces available like nasal pillow. This is a child on a nasal pillow. So the nasal pillow can be used in mild cases, and these are more tolerated by the kids because the full face mask leads to a lot of claustrophobia and they cannot tolerate the full face mask. But in certain conditions, when there is mouth breathing or something, you have to use the full face mask. This is a child on full face mask. You see there is a skin barrier which we have put, which is very important. So nursing care also is very important when the child is on NIV. This is a nasal cannula or Ram's cannula which you can use in infants to deliver NIV. These are full face masks which are usually available with us. Now the equipment required. So the mechanical ventilator is one equipment through which you can give. Then we have the CPAP machine and the portable ventilator. So while initiation of NIV, you have to see that there are no contraindications for NIV. You will do a baseline ABG. You will explain and reassure both the parents, and if the child is a little older child, you will explain to the child the whole process. You will select the proper interface for the child, considering his pathology and the proper size of the interface. You will select the ventilator and device. You will apply the headgear. You will hold the mask gently to his face and make the patient comfortable. You will not tighten the straps initially. Then you will connect the interface to the ventilator. Whenever the interface is applied, it has to be gently applied without fastening the head straps. You provide constant reassurance. When you start, you always start with only the expiratory positive airway pressure. And you have to start with a low level of expiratory positive airway pressure. Then increase the expiratory airway pressure slowly. And then finally dial in the inspiratory positive airway pressure. So the child tolerates it. If still the child has little discomfort, you can give sedative infusions. We usually use dexmedetomidine infusion on non-invasive ventilation. Response on NIV. This is very important. The physician or clinician has to be there bedside on the next to the patient for the first 2 hours to see how he is responding to NIV. So effective response, there should be improvement in the respiratory rate. There should be improvement in the heart rate. There should be reduced retractions, decreased use of accessory muscles. The oxygen requirement should be reduced. The FiO2 goal you should be able to achieve less than 50% to get a saturation of 92 to 95%. In case of hypercarbia, you would target a goal of pH above 7.35. If your CPAP doesn't let you do that, then you would go to a BiPAP mode. Close monitoring is the rule. This is the most important key lesson from this talk. Patients who fail NIV should be immediately shifted to invasive ventilation. Many deaths have been reported from failure to recognize patient deterioration. What will you monitor during NIV? You will monitor the patient's heart rate, respiratory rate, his work of breathing, the BP, the pulse oximetry, and alertness of the patient. Other variables to be monitored are adequacy of seal. Is there leak of the air? So the ventilation will not be delivered to the patient. Is the patient very agitated? So sometimes you can use sedation for that. Skin irritation and pressure points. So there are, after the use of NIV, even with the skin barriers that we use, many times we face skin ulcers. So you always have to be sure that you have put a skin barrier. We use deoderm, which is used as a skin barrier before putting the NIV mask, because it causes a lot of pressure on the pressure points, especially on the bridge of the nose. These children, when few days of NIV, they develop ulcers. Gastric distension. So the RT should be in place, and you should see that you are not delivering higher pressures. Ensure humidification is adequate, and both nurses and doctors are well aware of signs of deterioration. Now, troubleshooting on NIV. If there is low PaO2, you will increase the EPAP, or you will increase the FiO2. You can increase the inspiratory time or clear secretions. If there is high PaCO2, you will increase the IPAP. You will increase the backup rate. You will check for leaks and clear secretions. You can make sure that EPAP is above 4. If there is low PaCO2, you would decrease the IPAP and decrease the backup respiratory rate. What are problems and how to solve on NIV? So if there is asynchrony, you will try changing the setting. If you put on a nasal mask and there is a lot of mouth breathing, you will try and change the interface. You will try giving sedation. If there is high inflation pressure, you will identify what is the cause of this high inflation pressure. Is there atelectasis? Is there some bronchospasm? Is there pneumothorax? Is there pulmonary edema? Is there mucus plugging or consolidation? And treat individual problem accordingly. If there is cough, rhinitis, epistaxis, you would see what is the cause. You will see if your humidification is adequate. If there is bronchospasm, you will give bronchodilators. And if infection is the cause, you will treat it with antibiotics. If there is claustrophobia and the condition of the child allows, you may use nasal interfaces. Otherwise, you can give sedation to these children. To avoid gastric distension, you have to see that you are not giving higher pressures and the RT is in place. For mask leak, you will see that the mask is fitted correctly. And if there is mouth leak, you have to change to a full face mask. So, what are the problems we face in NIV? You may delay intubation and mechanical ventilation. So, NIV has to be used only in children who are in the early phase of ARDS, or you have to see that you select the patient correctly. The problems with the mask, there can be air leakage, there can be eye irritation, there can be facial skin necrosis, nasal or oral dryness, epistaxis, sinusitis. Gastric distension can be there. A lack of airway access and protection. So suctioning of secretions cannot be done because you have to remove the NIV, and for that time the patient loses the ventilation. Also there is a high risk of aspiration. Claustrophobia is also a problem, and it needs close supervision. The success of NIV depends on 3 things. The patient selection, most important, the equipment selection, and the clinician's skill. So learning points from this are, NIV reduces the need for mechanical ventilation and its complication. Timing is most important. Use it in the early phase of ARDS and in the mild cases where you can get off from the NIV, or also for liberation of patient from mechanical ventilation. Choice of interface is important. Modes which you have to select, you have to know. And close monitoring is quintessential for the success of NIV. Thank you.
Thank you, Dr. Soumya Renji ma'am. That was really a quick bite for us. I would now like to request the organizing secretary, Dr. Shika Agrawal, for felicitating Dr. Soumya. And now for the last session of on the intensive care, we have with us Dr. Abhijit Bagre, the lead intensivist from Apollo Hospital, and he'll enlighten us on colloids which are used in dengue.
Not recommend.
कैंसिल करा था कैंसिल हो गई स्लाइड शो
Good morning, everyone. So I am going to speak slightly gray zone topic today. It's use of colloids in severe dengue. Now, it is difficult to do justice in 15 minutes, but I'll try my best to do that. So it is one of the most common indications of our ICU admissions, especially in this part of this world. If we look at the trends of the dengue fever and how it has evolved in last 30 years, we spoke about dengue hemorrhagic shock. 25 years back, we spoke about dengue shock, 25 years before. 15 years back, we started speaking more of dengue HLH. 10 years back, we started speaking about dengue fluid overload, or that was a predominant complaint. And if you ask me today, my ICU colleagues would not shy away from saying, now we are seeing people slightly hesitant treating dengue shock and kind of restricting fluids when the patient is actually in shock. So that's the trend, what you have seen. We'll go through the pathophysiology difference, then how do we recognize, and finally dengue colloids, how, when, how much, why. So this is a typical dengue case, 18-month child, 10 kg, fever for 4 days. Day 2, met a pediatrician, symptomatic medicines. Day 4, he's highly febrile, tired, irritable, not eating well. In the morning, the labs were done. The child comes in the evening to the pediatrician. Cold extremities, last urine was almost 12 hours before. The child is now dull. HB is 13, hematocrit is 52, platelets are down to 22,000, NS1 is positive, and then the pediatrician refers this child to the ICU. So what we see in ER, conscious or febrile, heart rate of 160, cold extremities, CRT 6 to 7 seconds, BP is non-recordable, peripheral pulses are not felt, central pulses are feeble, RR of 35, saturation is not detected, air entry is okay, equal, no distress, but there is tachypnea and abdominal fullness, lever of 3 centimeters. So this child has already started going in shock. In fact, he is in shock, and there is good amount of leak. There is abdominal distension, not much of, as of now, not much of distress, and this is currently severe dengue with hypotensive shock. So course, we started with ABC, oxygen, 3-4 pricks. It was a difficult IV, secured a saphenous vein, sent the first blood gas, CBC, blood gas, CRP, a culture, LFT, RFT, coagulation parameters, and a blood group. This is not a routine protocol for all dengues, but this child is in shock, so we have to be slightly more aggressive about evaluation. Sugar is 80, and then a blood gas shows pH of 7. Severe metabolic acidosis, bicarb is only 5, lactate is 6.8, sugar is well maintained. So it's metabolic acidosis with elevated lactate. What do we do? We started with a 10 ml per kg normal saline over 20 minutes. 2 boluses have gone. After this almost an hour, heart rate is 160, slightly less by 5 or 10. Peripheral pulses are still not there. Central pulses are feeble. CRT is maybe a second less, and BP is now being recorded 68 by 52 by 57. Typically vasoconstricted BP, low pulse pressure, and saturation is still not getting detected. The child is still toxic and dull. Now, let's understand this. Is septic shock and dengue shock, are they different, and if so, how? So septic shock is typically hypovolemia. There might be a related vasodilatation, which is the predominant cause. There might be actually volume loss, like loose motions, vomiting. Then the EF is generally normal, or it may be low, typically when we see cardiogenic component also. And BP, at least in the beginning, it is wide pulse pressure with low, and when it is cold shock, it typically goes into low pulse pressure. So what is the treatment? Fluids, vasopressors, and we have to remember this child is vasodilated, so we have to fill in more. And a vasoconstrictor, a garden variety of warm septic shock. Dengue shock, what is it? It's fluid leak, but not fluid loss. The child has high SVR, so it is vasoconstricted. You have generally narrow pulse pressure, and you may see at times ejection fraction low, so component of myocarditis, and a relative bradycardia. This often misguides about assessment of dengue shock. Child may be in shock, but the heart rate is slightly low. What do we do? The treatment is fluids, unless you have something more. So 2 hours from admission, third bolus also is gone, and now urine output, we have catheterized the child. It is 20 ml. So it's not 2 ml per kg per hour, it is 20 ml in last 12 hours. Heart rate has dropped to 150, peripheral pulses have picked up, but they are still feeble. The BP is also slightly better, MAP is now 59. RR is 35, now it has become 38. Second IV also we have secured. We have sent a blood group, NT-proBNP and CPKMB to just rule out myocardial component. And the blood gas shows slightly better pH, 7.1. Lactate slightly better from 6.8 to 5.9. And hematocrit of 50 now. What do we do now? Should we add a diuretic? Should we conserve the fluid? Just start maintenance fluid? Should we go to 5 to 7 ml per kg? Or we go for a colloid bolus or a crystalloid bolus? I think these are the questions when it comes to us. And the other question, okay, do we start now vasopressor, maybe noradrenaline? Do we ventilate this child? So to understand this question, or to answer this question, we have to define this point. Has the shock resolved, or is it persistent, or is it improving, grossly improving? I think the shock here is definitely persistent. And how do we assess that? The most important and the easiest parameter is hemodynamics. The heart rate, the pulse pressure, the CRT, the warm limbs, core to peripheral temperature difference, urine output. This child should be ideally catheterized. We did so. And then blood gas, hematocrit, and maybe advanced centers, you can do abdominal pressure monitoring by just connecting a catheter, transducer to the Foley's catheter and an ultrasound to check for ejection fractures. So this is an important guideline. What do we have? Profound shock. So we started with 10 to 20 ml per kg. If the child is better, you are here, then you start tapering as per the protocol, 5 to 7 ml for 2 to 4 hours, then 3 to 5, then 1 to 2. If there is no improvement, we are in that limb, then again you have 3 options. Give another bolus. We have till now done 30 ml per kg. If the child improves, go to this limb. If the hematocrit is still on higher side, another bolus. Now what is that? Is it a crystalloid or colloid? We'll talk about it. And option C, if the hematocrit falls drastically, then you are looking at hemorrhage. And then the question of blood, whole blood or Paxil comes into picture. Now in spite of this B and C step also, if nothing is working, then we have to definitely look at, is it acidosis, is it bleed, is it the low calcium, is it the low sugar, and what else? We'll look at that. Okay, so what is a crystalloid versus colloid? Basically, colloids are fluids with high molecular weight substances and supposed to leak less and hold on the intravascular volume better. What are the natural colloids? Obviously, whole blood, Paxils and FFP, and then albumin as a derived product. And then synthetic ones are dextran, gelatin, and starch. So what options we use in dengue? One is albumin, which is a humanly produced derived this thing called molecule. The issues are cost and availability. The second issue is if it leaks out in the leaking phase, it may worsen, in fact, the respiratory component and cause more respiratory deterioration. The dose I have written, we have 20% or 5%. 20% works out slightly cheaper. So 1 gram per kg or 4 to 6 hours, you can take a photo of this. Dextran is coming from the fermentation of sucrose. 6 or 10% are available, microdex or microspan. And all the three complicating factors, so the complications are altered coagulation / allergy / the renal injury. If you give these synthetic colloids, if for a patient who is in shock and his kidney is already injured, that can worsen the kidney injury. The other products are gelatin, which is Hemaxil or Gelofusine. You might know them by the brand names. And the starch, that is Volumen or Heta starch. So the dose, now I spoke to around 20 people. I'll show you this slide. Let me go through the doses. So the gelatin or Hemaxil, they use 5 to 10 ml per kg for 1 to 2 hours and maximum 20 to 30 ml per kg per day. So you could use at 2 or 3 boluses, short boluses, or after using 5 to 10 ml per kg initially, then another 10 to 20 over 4 to 6 hours or 8 hours. And the similarly third case is also the starch is also used in a similar way. So what is the evidence? What is the controversy? So the WHO guideline, we all remember from 2009.
On 2024. So today we'll be starting initially with the oral paper presentation. For that we have with us two esteemed judges, Dr. Vandana Kumawat ma'am, who is the ex-HOD of RGMC and Kalwa Hospital, Thane. And we also have with us Dr. Mukesh Agrawal sir, ex-HOD KEM Hospital and at present the HOD at KJ Somaya Hospital. A warm welcome to both of you. Initially, we'll be starting with the oral paper presentations for the students, the post-graduating students. They have 6 minutes for their presentation and 2 minutes of the talk, the interview. So try to adhere to the timings. So the first student we have with us is Dr. Ashavari Bose. Please come on the stage. Start. Hello, hello, hello. Good morning to one and all. I am Dr. Ashavari Bose, Junior Resident Third Year, Department of Pediatrics from MGM Hospital, Navi Mumbai. I am here to talk about my study on micronutrient deficiencies in transfusion-dependent thalassemia patients. As we all know, thalassemia is an inherited group of hemolytic anemias due to ineffective globin chain synthesis. I am talking about transfusion-dependent thalassemia whose mainstay of management requires regular blood transfusions along with chelation therapy. Now, there are various micronutrient deficiencies which are noted in the thalassemic children. The primary etiology that has been cited for this is hepatic iron overload as a result of repeated transfusions. Other causes include poor oral intake, poor GI absorption, increased renal losses, increased oxidative stress, and use of chelation drugs. The manifestations of these deficiencies, there are two primary, the two most concerning ones are growth failure and cardiac dysfunction, and others are delayed puberty, limb pains, bony deformities, general malaise, hair and skin problems, eye lesions, and neurological manifestations. In majority of the instances, the micronutrient deficiencies often remain undiagnosed. The nutritional management of thalassemia, including optimum monitoring of the micronutrient levels in each patient and the act of subsequent supplementation, is usually overlooked in routine prescription owing to more pressing issues. The primary objective of the study that I conducted was to determine the prevalence of micronutrient deficiencies in transfusion-dependent beta thalassemia patients, and the secondary objectives included to study the clinical symptoms and signs of these deficiencies, to assess the diet and the anthropometric parameters, and to study the association of these deficiencies with physical growth, puberty, iron overload in thalassemia patients.
The study was conducted in the Thalassemia Daycare Center of MGM Hospital, Kamote, Navi Mumbai, and it included 70 patients in the age group of 6 months to 18 years. We took the history of the thalassemia as the disease, including age of the first transfusion, the annual transfusion requirement, the dietary history, details of ongoing chelation therapy, and cardiac MRI values for iron overload. And in examination, we looked into the anthropometric parameters, signs and symptoms of the deficiencies, and we estimated the pre-transfusion hemoglobin, the serum level of ferritin, and the 5 micronutrients that we studied in this study were vitamin A, B12, C, D, and zinc. The patient characteristics. The mean age of my study population was 9 years, and the mean age of diagnosis was 9.3 months, and age of first transfusion was 10.6 months. The mean pre-transfusion HB was observed to be 7.52 gram per DL. In the anthropometric parameters, there were 37.1% of children who had evidence of stunting, which is height less than -2 standard deviations according to WHO guidelines. 90% of the children had their weight within normal ranges, and 10% of them were moderately underweight. 97% of the children in the study population had a normal BMI level. For iron overload status, we looked into the serum ferritin levels. 40% of the patients had the serum ferritin between 1500 to 200, and 47.1 had less than 1500, and 12.9% had more than 2000 of serum ferritin levels. Accordingly, the chelation drugs used were either 1, 2, or no chelation drugs. We also assessed the cardiac MRIs for looking into the liver iron overload and cardiac iron overload. In 77.7% of the patients, there was severe liver iron overload, whereas in contrary, the cardiac iron overload was severe in only 11.1% of the patients. The prevalence of micronutrient deficiencies in this study population was noted to be 100% for vitamin C. That is, all the patients, all patients were noted to be deficient in vitamin C. 62.3% for vitamin D, 51.4% for vitamin A, 42.8% for zinc. The least prevalent micronutrient deficiency noted in my study was vitamin B12 with a prevalence of 8.7%. Among the signs and symptoms, the limb pains were the most common symptom that was noted among these children, followed by dental caries, and pallor was present in all. Correlation. There was a significant positive correlation that was noted between pre-transfusion hemoglobin and circulating vitamin B12 level. This means that a patient with a well-maintained pre-transfusion hemoglobin level was less likely to suffer from vitamin B12 deficiencies. The micronutrient levels were also correlated with serum ferritin levels, and a significant positive correlation was deduced between serum ferritin and zinc levels. We also compared the median serum zinc values among patients who had stunting and those who did not have stunting, and it was found that the median serum zinc levels were found to be significantly lower in children with stunting than those with a normal height. According to TIF guidelines, it recommends supplementation of vitamin D and calcium in all patients with monitoring of vitamin D every 6 months. Vitamin C supplementations are recommended in conjunction with deferoxamine infusions or if the deficiency is proven, and supplementation of zinc in patients with growth abnormalities. However, it is not advised routinely for all patients. As our study highlighted a significant role of zinc deficiency in growth failure in TDT children, in concurrence with other studies conducted in the past, zinc monitoring and supplementation should be routinely incorporated for optimal growth. The prevalence of micronutrient deficiencies in our study was high, especially vitamin A, C, and D. Hence, we would recommend annual screening of clinical findings, growth parameters, serum micronutrient levels so that adequate supplementation can be initiated in a timely manner.
Thank you. Good morning.
Good morning, sir.
It is a good study. I have two queries,
Yes.
comments, this thing. Number one, what do you think, apart from the iron, other micronutrient deficiencies are somewhat related to the thalassemia per se, or they are just coincidental findings in these cases?
Actually, it is secondary after the development of thalassemia. In a country like India, mostly.
How do you know that it is after the development of thalassemia?
Sir,
Because you have not done before that.
Yes, sir. Yes, sir. It could be present even before the development of thalassemia as well, sir. Yes, sir.
So that is one thing. And
Yes,
secondly,
sir.
what test was done for the vitamin C levels?
So, it was a photochemical method. Biochemical assays were done,
Testing
sir.
what? Testing in the RBCs or
No, sir. Serum levels, sir. Serum levels.
serum?
Serum levels were done, sir.
Okay.
It was a good presentation,
Thank you, ma'am.
but your age variation was too much. 6 months to
18 years. Yes, ma'am. Yes,
So
ma'am.
like the variation was
Yes,
too much.
ma'am.
And how did you conclude? One.
Yes, ma'am.
Second, like you say it is a zinc deficiency. Was zinc deficiency correlated with your number of transfusions and ferritin level, you say?
Yes, ma'am.
But then, like, it depends upon the number of transfusions or chronicity of thalassemia?
Yes, ma'am. Actually, in most of the studies that I had reviewed, ma'am, in that they had said that the more the annual transfusion requirement, more is the serum ferritin level and lesser will be the zinc levels in their serum.
Yeah, yeah.
But according to our study, actually, there was, because I think of this long age gap, ma'am, the cohort was such that this finding that I found was that serum zinc level was had a positive correlation with serum ferritin. But in most of the studies, it was the opposite, ma'am, actually. Yes, ma'am, it was actually the opposite.
So
Because,
what message would you give then?
ma'am, because I had found a positive, the significant role of zinc in stunting, ma'am. That was a significant finding in my study. So growth failure and growth retardation is found in thalassemia patients. So that could be attributed as one of the causes could be zinc deficiencies. So I would like to recommend that zinc should be routinely monitored and then we can give supplements to the patients who are deficient. After proving the deficiency, we can go ahead and prescribe the zinc supplements, ma'am.
Okay. Thank you.
Thank you, Dr. Asavari. That was a wonderful presentation. Now I would like to call upon the second speaker for today, and that is Dr. Gaurav Janwar to present his paper.
Good morning, everyone. I thank the organizer for giving me the opportunity to present my research entitled on acute watery diarrhea in children, under 5 children, and their prescription analysis. Faulty prescriptions have many implications. With the headline like these, the public trust in doctors and healthcare get compromised. So acute watery diarrhea is a major public health problem in under 5 children, as it is responsible for morbidity and mortality. As all of us know that oral rehydration therapy, appropriate diet and zinc are the mainstay of the treatment. However, many studies have reported unnecessary use of antimicrobial agents and underuse of ORS and zinc. The prescription is a communication from the doctor authorizing the dispensing medication, and the special instruction are given for their proper use. Improper instruction written in the prescription can lead to error in administration. This can lead to underdosing, overdosing, and inappropriate frequency of administration. Indian studies have found
A. Barucha, 21/9/55 to 11/10/1998. Sir was an undergraduate and postgraduate student at St. G.S. Medical College in KEM Hospital. He was well known as a brilliant student and topped all exams, undergraduate, postgraduate, collegiate, and university level, and secured a rank at DCH and MD exams, following which he opted for a full-time teaching career at KEM Hospital. His home was KM Hospital and his family the pediatric department. He was an extremely dedicated clinician and a passionate teacher. He was the most sought after teacher by all the students from Mumbai and also all over the state. His UGs and PG students remember him for the depth of his knowledge and dedication towards teaching and patient care. People knew him for his excellent teaching skills. He had set high academic and teaching standards. He particularly enjoyed seeing and discussing difficult cases, and students would be eager to attend his ward rounds. He was very easily approachable and used to enjoy the company of his students, as was evident in his 6-monthly dinner treats for his unit faculty and students at the CCI club. Attending the UG quiz conducted by him was an eagerly awaited event. His knowledge in clinical genetics was unparalleled. Pediatricians all over India admired him for his great contribution towards the subject. He was a great human being with a tremendous urge to help the needy patients and would spend lots of time in the OPD and wards. His love for medical reading and writing is evident from his publications seen on the PubMed even today. His mastery over the subject of pediatrics, ranging from growth and development, breastfeeding to genetic syndromes and IEM, had to be seen to be believed. He contributed to IAP in a big way. He would be present for the election result counting every year till his sad demise. He participated in all the IAP activities aimed at promotion of breastfeeding. He was the one of the pioneers to start a special clinic for patients with Wilson's disease. His untimely demise left an enormous void in the lives of most of his colleagues and students. His students and well-wishers have formed the foundation, and the oration is one of the activities conducted along with IAP Mumbai. Our team, IAP Mumbai, this year considers itself honored to host this Professor B.A. Barucha oration. Before proceeding further, I would like to acknowledge the presence in the audience of dignitaries closely associated with Professor B.A. Barucha, Dr. Archana Kher Madam, Dr. Sandeep Bavadekar Sir, Dr. Mamta Muranjan Madam, and Dr. Milind Tullu Sir. I now call upon IAP Mumbai President, Dr. Nehal Shah, to introduce the recipient of the oration.